Hello, hello. I am excited for today because we're doing something differently. We are opening up our session to everyone. I wanted to go live, but looks like we'll probably have to go live on the next session. But as for today, we are recording, so everything is being recorded for access later. And as everyone know, I start promptly, so I will get started. Now, as you join in, I do ask that you save your questions for the end. Just place them in the chat, and then we can go through each question afterwards. Okay. So let's get started. I'm so excited to be breaking down congenital heart defects. I feel like, is there a thing where you can say you're always or you feel so comfortable and confident in congenital heart disease and recognizing those pathologies during ultrasound? Uh, I, I guess you will to a point, but I even after um, all of my extra years of scanning, I'm still not to the point where I feel so confident in recognizing these structures. And it's only because it's different. Pathologies can appear differently. Even the same pathology, I've seen different variations of the same pathology, but it appears differently for some reason. And so I hope with these sessions, I came up with some like clever things where it will help make it easier to recognize when something's off when you're evaluating the heart. Now, why I chose embryology in this process is because simply if you know or understand the breakdown of how the heart is formed or developed, then it makes it easier to understand when there is a error or a problem in that development. And so let's get started. Now, this is just part one of the breakdown because, as you know, there are several congenital heart defects and they all have different reasons to why they were formed. Okay, so we'll just discuss a few today. Now, some possible causes of congenital heart defects, it varies. It could be a genetic issue, it could be due to chromosomal issues or environmental factors. There are some medications that may cause a heart defect. And so patients are at risk of having that with their fetus, as well as some other risk factors such as diabetes, obesity or advanced age. Okay. Now we have all the possible causes listed here, but we missed one. It could just happen. It could be no reason at all, and still a heart defect may develop. Okay, now there are different steps into heart formation. What I listed here are six eras that could occur during the process of heart development. So we have one through six. The ones that we'll be discussing today are the first three. So we will go over tissue migration eras, abnormal intracardiac blood flow errors, and then also cell death errors. Now, part two, we'll be discussing sections 4, 5, and 6. Okay, now I do want to mention we will talk about some situs and lupin errors that could go wrong and what defects develop from those errors, but we'll go more in depth in part two. All right. Now, as you may know, VSD is the most common congenital heart defect. Okay. And then I have the list here. Next will be PDA, followed by ASD. And then you can see with the stenosis of both pulmonary aorta, coarctation, tetralogy, and transposition. Okay. Now, what we'll take a look at today, we'll look at VSD closer. We'll take a look at ASD as well as tetralogy. All right. Now, you may hear this, especially if you ever took a embryology class dealing with heart development. You may heard these verbs before, okay? And so, especially persist. A couple of our heart defects has the word persistence in it. And so, we're going to go through each one of these steps, starting with formation. Okay, followed by fusion. What do we see? Because the heart starts off as a single tube, and then there's some fusion that will take place. And then from there, we have a looping of that tube, which it should be looping towards the right. Okay, followed by septation. Okay, now notice there's 8 steps in this development. By the midway point of step 4, notice we're starting to see what looks like a 4-chamber heart because this is where that septation occurs. Okay. Now, once we're at septation, we do have some spiraling. So when you think of a spiral, you think of that crisscrossing of those great arteries. And so spiraling happens after septation, then follows remodeling. Okay, so we have some things where the cushions and the outflow structures are being remodeled, and then from there they'll take on a regression and a persistence afterwards, and that's at the end. Okay, now this development follows this sequence in this order. Okay, so if there is an error, say at step 3, then it will lead to a heart defect. Okay, now before there is a single heart tube, there is a merging of these vascular spaces or blood islands into this single vessel, okay? And that's known as coalescence, okay? Now, the merging of these small separate spaces will join together, and then we will have that single vessel heart tube, okay? Okay, now this fusion has to happen. If it does not occur, then we will never have the single heart tube that takes place. Now, say like as those vessels, those vascular spaces are joining, and there is an error that happens, then this is what is the result of that. It appears to be either a hole in the heart. Okay, we're missing some space there, so it causes a hole or separation, a common junction, or a persistent connection. And so from there, I wanted to list what you see the defects that are associated with this abnormal fusion, okay? And you're going to recognize a few, okay? So we have AV septal defect is one. When you think about that hole in the heart, that is an AV septal defect. Another error that may occur is a ventricle septal defect, and this one leading into the paramembranous portion. Okay, so that's right off like that LVOT section. Or you may have a persistent truncus arteriosus. Because remember, there should be some split and some separation. Instead, that trunk stayed as one. And so then you'll have a persistent vessel in that case. Okay, now aorta pulmonary window is it's pretty rare, but it can still happen. And that's due to this step, due to this error in this step here. And that's where you see that connection between the aorta and the pulmonary. And then lastly, double outlet right ventricle. Okay, and with the VSD. Okay. So when you think about the merging of those scattered vascular spaces into that heart tube, they should come together. However, if there is if they don't properly meet or fuse or integrate, then a hole, a common junction, or persistent connection will remain. All right. Now, when you have the merging of these vascular spaces, endocardial cushions is a part of that process. Okay. Now, what happens with the endocardial cushions? I laid out an outline. I kind of compared it to think about it as if you're a builder of a house. And so when you think about the endocardial cushions, they are what lays the foundation down for the heart central structure. So already you see if there is an error in that process, that's where that hole will occur in the center of the heart, where those heart meet and come together. The chambers and the ventricles and the septum, they have to meet in the crux. And if there's an error in this result, then there is no joining of those chambers. Okay, so then it will lead to a hole there in the heart. Now, from there, we have to build the walls. Okay, we have to build the walls. What are the walls? The walls are what separate the ventricles as well as the atriums. And then we have to create the doorways because blood has to go in, right? And so through the doors, it's the tricuspid, the mitral valves. Those are the doors. That's how the blood flow into the ventricles. But what happens after that? We need the hallways, and the hallways are our outflows. Okay. And so that's where we have the aorta outflow and the pulmonary artery. Those are the hallways from the framing of those doorways. Okay, so I hope that analogy help understand it, the breakdown and the importance of the endocardial cushions. Okay, very important with the heart formation. Okay, now take a look here. Here we have an example of an AV septal defect. Okay. Now, some doctors still use the term endocardial cushion defect. Now we understand why, because we know that the process of the joining of the crooks is the process of the endocardial cushions merging together. And so when there is a error in that joining, we have a endocardial cushion defect. And as you take a closer look, notice the hole here, okay? Completely opened, and there's no joining of the structures here. The septum should be joining and creating the crooks there in the center. But as you see, there's one big hole here in the center. Okay. Now, another thing that the endocardials, which we saw already, is creating the walls there in the house. Okay. Now, starting with the septum primum, that's right where it's the inferior portion of the atrial septum near the endocardial cushion. Okay. And then you can see here with the septum secundum that forms to the right of the primum, as you see here in the video. Okay, now the lower portion there has an opening, which is naturally normally there for the fetal circulation, and that's the foramen. Okay, that does not close until after delivery. Okay, and you can see where the blood is naturally flowing through the foramen from the right atrium to the left atrium. Go take a look at that again. Okay. All right. So let's take a look here. What's happening here? I'll play it again. You see what's happening here? Let me try to slow it down because my video is a little fast. So let's see if I can make this a little slower. So unfortunately, we had this case this week actually at my job, and it was missed. It was missed. We did pick it up later on, but it was missed at the level 2 20-week scan. That is the screening time where we are looking at these heart to make sure they're okay. And so right away, we can see that there is a disconnect here. Okay. And also, another thing that stands out, with the AV valves, I want to pause this. With the AV valves, there is a higher insertion of the tricuspid valve, but notice here it's a linear insertion of those AV valves. That's usually one of our red flags when we're evaluating the heart. But then look here. Where is the septum primum? We just talked about that and the formation with the endocardial cushion, and notice it is not there. And so this is indeed AV septal or maybe ASD. We're still going to do our evaluation because she's due for her echo coming up. But right away, we see that there is a linear insertion of the AV valves, and there is no primum here. So that leads us to the one of the two. Okay, and I will know by actually our next meeting what the cardiologist came up with once we did a further investigation. Okay. But when we talk about atrial septal defect, which we know with the AV septal defect, that includes a primum defect as well as the inlet defect of the VSD. And so it's a combination of the two that where you will get an AV septal defect. But if it's just the ASD separate by itself, then you have it known as the ostium primum defect. And that's where we saw right at that atria, at the crux. It should be there, but it is indeed not. And so it leads us to believe that there is an ostium primum defect in that particular example. Okay. Now, ASD is the third most prevalent congenital heart anomaly, which we saw in that list earlier, right under VSD. Okay. Now, with that formation of the septum, there is three parts. The initial phase starts where there is no primum. Notice at the initial phase, it looks similar to the defect that we just saw in the presentation. Okay, so that was at the initial phase, but from there, that's where we have the formation of the primum and the second phase. And by the final phase, we all have the completion here. So it looks like with our particular example, things went wrong right at about that initial phase of formation. Okay, now we're getting into the linking up of two separate vessels that will eventually create a new pathway. Now, I love using different analogies because it really helps understand these big words and terminology. And so for this particular example, I compared it to roadways. Okay, so from step one, we have the big merge of the tubes, which we saw there in the beginning. So you can see, followed by the two streets merging into one. We all know that that's like a merge on basic streets as if you drive or so forth. Now from there, we have to build this like plumbing system. And so that's where we have these vessels, like the mesh, vascular mesh, and the connections of the blood flow. And so that's similar to those pathways that we see off of those main roadways, the major highways, or so forth. I love the analogy of the coronary arteries, which will create like some bypasses and so forth. And so you can see that in our analogy of the roadways as well. Now, by time we get to the end, that's when if connections go wrong, When connections go wrong, then we lead to some examples where we have some abnormal coronary artery connections, as well as structural defects. And so we're going to take a closer look into what could possibly go wrong in those cases. Okay. Now this is I did spoke of earlier that we were going to talk a little bit about the lupin and the spiraling and the septation phase, only because it is an essential process in the heart development. Now I did list the errors that could occur in each one of these phases, starting with lupin. Of course, when you think about lupin and how the heart should loop towards the right, in cases where it looped to the left, then that will cause like transposition of the great arteries. You see here, L loop ventricle with LTGA. It even occurs in double outlet right ventricle, as well as in heterotaxy cases. Okay. Now notice in each one under lupin, spiraling, and septation. Oh, did someone have a question? No? Okay. In spiraling, you may see here the same disorders that could occur in each one. With the spiraling errors, that's with the result of tetralogy, persistent truncus, transposition again, double outlet, and here interrupted aortic arch. So that's due to a spiraling issue that occurred. And then for our septation, which it really just really makes sense in its name, if there's a septation error, then we'll have some type of septal defect, whether it's ASD, VSD, AV septal defect, tricuspid atresia, and pulmonary atresia. Okay, so let's take a look. Let's go a little deeper. Now, with that lupin, what's interesting about this is that this lupin phase has to occur in this particular way, meaning it has to loop towards the right, okay, from that straight heart tube, and that's how the ventricles are set in their place, as well as the atrias in their correct spots. Okay, so it only makes sense if it took a leftward turn, how things will get switched around in those cases. Okay, now as we're looping, we're migrating at the same time. It may not appear that way, but there is a migration process that is happening during this looping process. And so it's important for the migration of these cells to go to their proper place, because that's how we get the separation between the valves and the septum. Okay, so let's take a closer look. With the tissue migration, you can kind of see here with the migration that's happening. So you have those cardiac neural crest cells. You see where it comes from, that single tube. I do want to point out how the aortic or the aortic sac is on the top portion. So you think of like your aortic arch versus here, we have the primitive ventricle. Okay. Now from there, that migration of those cardiac neural crest cells migrate, and they migrate into the truncus and the outflow tract cushions. Okay, so you see where they're migrating. Now, normally they should start some type of septation or separation that happens. Okay, which you can see where it kind of build up there, here in the center. Okay, and so then that's where that spiraling starts to happen and a separation will occur. Okay, now from there, that third portion will start with the truncus divided, and that's where we get our great arteries. You can see here the aorta and the pulmonary artery. And it's only natural. If it does not occur or something goes wrong in this process, then that's going to create an abnormal vessel alignment. We're going to have an outflow tract issue as well as a septal defect issue. One of the three, or it could have all three. Just really depends. Okay, so we're going to break down each one believe I'll start with double outlet first. We'll see. But with the tissue migration, there's just a disruption that happens with those tissues, and it led to an abnormal separation of that truncus. And so let's take a closer look into this here. Okay, so double outlet right ventricle, there's four types. One thing I do want to mention with double outlet right, almost always there is a VSD that's present with this. Okay. Now, the definition or proper definition is where there is a condition where there's 50% of the aorta, okay, aortic root and the pulmonary artery that both arise from the right ventricle. Now, the question is, or how to know the difference between the different types, is really where that VSD is present. And that really helps you in which type is present. Okay, so let's take a look. We'll take a look at each one. When you say, like, you suspect you're scanning and it appears that are your outflows are on the or coming from the right side, you want to ask yourself few questions as you're scanning. First, where is the VSD in relation to the great arteries? That's going to help tell you which type is present. Is there a pulmonary stenosis or any other obstruction seen? And then what do it resemble? Okay, does it resemble a very large VSD or tetralogy or transposition? Okay, and you'll see why as we go through each particular step. Let's start with this one in particular. Okay, so the double outlet with a subaortic VSD, I put here on the side so you can see what it will mimic. And so with this particular one, it mimics or tend to mimic a tetralogy. Okay, and that's simply because the VSD points to the aorta. Okay, and almost looks like a overriding aorta, which we know that that's classic in tetralogy. Okay, and tetralogy of flow. So the VSD lies beneath the aorta. Okay, so that's allowing that blood from the left ventricle to cross that VSD and enter that aorta directly, which we can see here. All right, now this will cause mixing. Okay, mixing still occur since both great arteries originate from that right side. Now, this may have a resemblance of that large VSD, unless there is you see a narrowing in the pulmonary, and then that can make it mimic the tetralogy too. Okay. All right. So then the next type is the one where this instead, the VSD is near that pulmonary. Okay. Now I put here, this one here in particular is a variant to recognize because it's similarity to a transposition of the great arteries. Okay. Now, this one's different from the first one we discussed because in this case, the VSD is pointing towards the pulmonary artery, which we could see here. Okay. Now, that VSD is located beneath that pulmonary artery, and it's allowing the flow into the PA instead of the aorta. In this case, it will mimic that TGA. It almost looks like a parallel circulation in this particular case. But instead, they are both coming from that right side. Okay, and then we have one when there is a doubly committed VSD. So what happens there? In that septum, we have that VSD and blood flowing sits here between the aorta and the pulmonary. So the VSD is pointing towards both great arteries. Now, this one is similar to a very large VSD, and this one often presents a left to right shunt, okay, leading to the heart failure. Okay, but it's a shared communication from that large VSD, and it's connecting to both the great arteries in that case. And then lastly, we have one. This one is really severe because this one, the VSD In the case of double outlet right, the VSD in the first three types are helping blood still get circulated. But in this particular case, this VSD points to neither. Okay, this is like one of the most severe type. It's also known as univentricular type. It's severe associated with mitral atresia because of the lack of the blood flow. It's hard for the blood to reach to these outflows. And so we know when there is a lack of blood flow, then there is no distribution of blood moving through these chambers. And so functionally, we have a single ventricle circulation. This requires uh, help immediately, right away. Okay, but this one is the more severe out of the double outlet, right? Right, and that's because where this VSD, it's not allowing the blood to circulate to the great arteries, and so that's why in this particular case, it is really tough for the circulation to reach the great arteries. It's usually a higher VSD, way, way up into the apex, usually for this particular one. So it's non-committed and it's remote. All right. Now let's go through the process of we're scanning. Okay. Now take a look at step one. Step one, we're at the four chamber view. Now, because we are talking about outflows being connected to the right ventricle, the four chamber may look normal, especially if it's initial phase. Now, in the case where we saw in type 4, later on, I'm pretty sure that four chamber view is not going to be normal. But this is like an initial phase where things are still kind of circulating. Okay. So the four chamber view may not give it away. Okay. You may not even suspect that there is something going on from this level. All right. So now it's when we're doing our heart sweep. We're like, oh, wait a sec. What's happening? Where's my aorta? Where's my pulmonary? Why are there, it's connected here? And so this is where we're going through to demonstrate our crisscrossing. We notice the LVOT aorta is anterior, which shouldn't be. And so this is where we're like, okay, we need to do some investigating what's going on with the outflows. And so from step 3, then we notice, oh, there's a VSD. Okay, I see that there's a VSD. This is when you want to start investigate. Okay, is it pointing towards the aorta? Is it pointing towards the pulmonary artery? Is it a really large VSD? This is how we're, just talking it out, going through those steps of what's happening, as well as is it presenting 90 greater than 90% of the double outlet? Like what's going on with the septal defect? Okay. And so as we trace the aortic root, we're to step 4, we notice that it is mostly coming or arising from the right ventricle. Okay, which we can see here. You see where the VSD is. Okay, so that's a definitive clue. If you're connecting the aorta to the right ventricle, whether wholly or partially, that's usually your clue that we're dealing with a double outlet. Okay. And then we're going to compare with the pulmonary artery. Where is it arising? Are you seeing it arising from the left ventricle, or is it too arising from the right ventricle? And so typically in that case, that's when you can differentiate, oh, yes, they're both arising from the right ventricle. And then we can pretty much say, yes, we're seeing a double outlet right in this particular case. Okay. Now, as we mentioned earlier, the different types, and that VSD is what's going to help you know which type you're seeing. So whether it's anterior beneath aortic valve or pulmonary, or is it doubly committed? So that's really a large VSD connected to both of those great arteries, or is it remote? Okay. All right. And then some common associations that I wanted to add with this, it may not be a long one. I mean, we know it's going to have a VSD, but it may have pulmonary stenosis, which we saw in the different types. It may be associated with coarc or interrupted aortic arch or other types of aortic arch anomalies. And then there is some genetic associations with double outlet, right? And so the patient will definitely you want them to go through those other testings as well. Okay. Once you suspect that there is double outlet, of course, we will have to perform a fetal echo in that case and do a full evaluation of everything. And so then lastly, I do want to point out the pathway again. We always start with that four-chamber view anyway, I feel like, as we're evaluating the heart. But starting there, it may look normal. Then as we're doing our normal heart sweep from LVOT to RVOT, once we notice that there's no crisscrossing, then we look, is there a VSD present? Okay. And then just go through those necessary steps that we just discussed. Okay. All right. So let's go into septation. Okay. So remember earlier we were talking about endocardial cushions and the building of the walls and the frameways and so forth. So this where we're getting to that process of the septation. This was at that halfway point of development where this occur, and we're started to see four chambers. And so with septation, what goes along, as we saw earlier, is with the separation of the truncus. Remember those neural crest cells, they have to join into the truncus, and there's some spiral and some separation. And this needs to occur. If it does not occur, then we have one big common trunk of a vessel there in the middle of the heart. Okay, so it should naturally occur. All right. Now, here are the list of things or the errors that will occur if there is an abnormal septation. Okay. So we have an ASD, which we saw earlier, followed by a VSD, AV septal defect, and then tricuspid atresia. Okay, so when septation is disrupted, these are the defects that will occur in this process. Okay, so let's break this down. So we saw this here. Yes, so I do want to go to here. Okay, so notice and take a look at number one. Okay, because if any truncus arteriosus, it looks just like this, and I have a picture, so I'll be able to share with you. But it appears just like this. There's a truncal vessel, and then you have these. You see here these like pulmonary arteries or so forth, kind of like protruding at the end of this trunk. And it appears just like this. And so when you see this in real time, it's like it looks just like your textbook picture here. Okay. Now another septation defect is tetralogy. Okay, so tetralogy we're gonna discuss further coming up, and we just went over the double outlet right ventricle. Okay. Now, one thing I do want to mention, which we won't really get to go into transposition today, but I do want to mention, far as if there's a spiraling defect that takes place, then we will have the crossing of our arteries in the wrong place. And so we'll have the switch in the pulmonary artery is attached to the left ventricle and vice versa. And so that's where the spiraling defect happens, and it causes this defect. Okay. All right. So let's take a look here. So here we have in the red box, this is a defect. Okay. And then in the blue box, this is a defect. Now, when you compare the two side by side, are they the same? You don't have to answer, but just think to yourself, are they the same defect, different patient, or are we looking at two different defects? Just take a mental note. Okay, and then we're going to actually look. I do want to point out we're actually looking at two different defects. One is a tetralogy and one is a truncus. All right, but we're going to go through. I'm not going to tell you which is which. We're going to look at these separately. So with truncus, here I was able to find a CT scan of a truncus, and what about this particular one? It almost looks like a trunk of an elephant, just upside down. But I was like, wow, look at that. But you can see where there is this trunk of a vessel in the center of the heart, which we can see here. Notice that there is one single truncal valve. Also, what they're pointing out is the VSD. Okay, so trunk is pretty rare. There is a VSD, which we can see. There is a single truncal valve, and there is one common outflow tract for both ventricles. Okay, how is this trunk receiving blood? Is receiving blood from the ventricles through the VSD, and it's entering through that one truncal valve. Okay, so that allows that mixing of blood. The pulmonary arteries branch directly from the truncus. There's different types, so it may not always just branch from the bottom. It's different types, which we'll talk about. Okay. All right. Now it's pretty rare. One thing I do want to mention: the truncal valve may have 1 to 4 cusps. Most often, three are there. Okay, but when you think of truncus arteriosus, it's one trunk, one valve, one big mixing problem. These are the associations that it could be seen with. A lot of times you're going to see that these heart defects are in a combination of other defects that went wrong as well. And so it could be either an aortic arch issue or an abnormal coronary issue or PDA, secundum ASD. I mean, it's various things that could go along with the truncus. Okay, now I wanted to kind of blow up on the, you can see here the leaflets associated. This in this particular case, oftentimes it's usually three, but in this particular case, you can see where there are actually 4 leaflets. And so I wanted to share that with you so you can see what that looks like. Okay. Now with this one, what happens here, which we saw, the neural crest cells, remember, they should go into the truncus and they should cause this separation, but something went wrong there. And so there was a failure of this trunk to separate, because remember, it starts off as single tube, but it should separate, and it did not in this case. Okay, so it resulted in both a common trunk as well as a VSD. Okay, now here are the different types. Now, type 1 is the most common type. The pulmonary, and it's all about where the pulmonary arteries are to know which type you're seeing. And so with type 1, what happens here, the pulmonary artery bifurcates into the left and right. These will arise from the ascending portion of the trunk. So from the top portion of the truncal vessel. The second type is where the right and left instead arise from the posterior truncus, okay, which is demonstrating here. Then type 3 is where the pulmonary arteries arise instead from the sides of the proximal truncus. Okay. And then type 4 is also known as pseudotruncus, have none, absent pulmonary arteries. And in this case, we will have those collaterals. Or think about an anastomosis, where at the end, they had those collaterals and those bypasses and so forth. So the heart is still trying to make a way to get this blood moving. And so it creates these collaterals of flow since the arteries are absent in this case. Okay, so here once again, we can see where we have a VSD. It's more from like the 3-vessel view or trachea view. And you can see where there's one common trunk and you have a thickened valve. Okay, and naturally, when you apply your color Doppler. We can see a color Doppler. We see that there is some insufficiency, followed by you see the turbulence and so forth. So when we add the pulse wave, and notice there is the insufficiency seen. Because remember that truncal valve is not functionally normal, and so it's thick. It's almost like stenotic in a case, and so that's where we have that insufficiency in that case. All right. Now, in the three vessel view, this is how it would appear. Notice we have the three vessels, but you see where things are taken over there in the center. Note that small, teeny tiny pulmonary artery. We have the large aorta. In this case, too, it could have a very small thymus, which we know that that could be correlated to a microdeletion, okay, the thymus gland. Okay, now we're moving on to tetralogy. Now, I just had this case like 2 weeks ago, and I put the different variations of the pictures as through my scan. Notice starting with my situs, you see here, because I typically try to start with situs and confirm situs is normal. There was no speculation of anything that could be possibly wrong with this heart at the situs level. Like I had no clue. Even once I got to four chamber, things looked pretty normal, and I put my color. And so I was thinking, is this dropout? As you can see, which we know is common when you're at your apical level. But then when I go to my sweeping of my outflows, or naturally doing my sweep to demonstrate crisscrossing, this is where I start noticing things. I'm like, okay, what's happening? Why is there this angle here of this LVOT? It appeared that it was like overriding dramatically over to that right side. And so that was my first clue. And then I'm still sweeping. Notice, oh yeah, there is a VSD. There is a VSD that I did pick up, which you can see here. You can also see at that overriding, you can see where I measured a little VSD there. But upon my three vessel trachea view, look at the pulmonary, how small it is comparative to the aorta. Yeah. And so, as we know, tetralogy, to have those three classic ones that we will see: overriding aorta, VSD, pulmonary stenosis. We will, or you may see right ventricle hypertrophy later on as a result of that pulmonary stenosis later on. But initially, these three findings will suggest a tetralogy of flow. Okay, so I really wanted to talk about this override and how it drastically is at this angle where it's overrided into that over on that right side. Okay, and so is classic in tetralogy to see this displacement of the LVOT. Okay, and also notice its relation to that VSD as well. Okay, so the aorta will override the VSD, typically is on that anterior side, which we saw, and that as a result will have blood entering from both ventricles into that overriding aorta. That is that drastic angle. Okay, so let's walk this through. Let's talk this out. So, like we saw from a situs level, the four chamber, things were looking good. It was, like I said, I didn't suspect a thing, but as we're doing the sweep, that's when we're like, okay, from that LVOT, what's happening? It's overriding drastically over to that right side. What is going on? Oh, there's a VSD, which I believe that's step three. Step three, that's when we notice that VSD. Okay, outlet, things are happening. And then from there, we're looking at that pulmonary, where we notice that there is some stenosis or narrowing of the pulmonary artery. And so, you take a step further, you measure You measure, you apply your color Doppler, you even sample just to hear if there's any changes from natural or normal. Okay. Now, I want to show the difference. Okay. So, tetralogy, we still have two separate outflows. Okay. We have an aorta, we have a pulmonary. The pulmonary is a little smaller, but they're separated. Whereas with truncus, there's one common trunk of a vessel there. Okay. So that's two roots versus one root. That's the key difference between those two. And then from there, we can see, yes, there is still a VSD, but what stands out between the two is the fact that that common trunk is one trunk of a vessel versus the two that you will see with tetralogy. All right. Now, some associations to consider. They vary with the different ones that are present. With tetralogy, we know pulmonary stenosis is associated, right aortic arch. Remember that 22q deletion could be associated, other defects, as well as VACTERL that's occasionally seen with tetralogy. And then with truncus, same though, same has the George association as well as interrupted aortic arch. Okay, but what really stands out, and I feel what stands out is that common trunk of vessel with the truncus that is seen versus tetralogy. Okay. Now let's look here. What's the diagnosis? Okay, we're looking at this picture. Okay, and we see that if you look here, we see there's a VSD. We see the connection between left and right ventricle, and then followed by one common trunk of a vessel there in the center. And then we can see the branching of the pulmonary arteries there at the bottom. So from what we just saw or what we just discussed, we do know that this is a example of a common arterial trunk, which is also the name for truncus arteriosus. Yeah. But you see this when I scan this patient and I'm scanning, and when I went to the outflows view and saw this, I knew right away, just from because it's classic to that textbook picture that we saw earlier. So now when we look at this, we can tell the differences here, where we can see, especially in the blue box, we have one common trunk of a vessel. We see where there is that thickened truncal valve. Okay. Yes, there's a VSD. We do see the VSD present here, but you can clearly see the differences and know that this is truncus or common arterial trunk versus the tetralogy in this case. All right, so we're getting down to the end. So now we're going to talk about atrium versus the ventricle septation. Okay, this is a complex process, which is it makes sense that VSD is one of the most common defects because of the process of its formation. It's amazing that we don't see a VSD in almost every patient because of this complex process during development. Now, as for atrial septation, is an active process. The atrium is splitting into those chambers. This process is called septation. Okay, so it's an active process. When we talk about the development of the ventricles, is more passive. Okay, so the ventricle is divided into the two chambers of the septum, and it's more passive compared to the atrial septation, which makes sense. So what do we say? 30% VSDs are present versus the ASD, which is about 8%. Okay. Now, the formation of these ventricle septum, although it's complex, it has to have that proper membranous septum. Okay, so remember the tissues have to connect with the endocardial cushions, the ridges, and the muscular septum. They all must grow and form together correctly in order for there not to be a VSD issue. Okay. And naturally, if there is an error, that's where the VSD uh, defects come about. Okay. Because it has to come in this process, in this order. Okay, and you can see the formation here. Now, remember with ASD, how we saw the initial phase for ASD, there was three different phases with the atriums to, form. And notice with that ASD where we saw with the primum, that was the initial phase where that defect had occurred. And so you can see the different phases happening here in this formation, in this development here. Okay, so it looks like we missed that second step as we saw in that formation of the atrium. Okay, all right. Now, VSD, there's several, depending on where the error occurred, where the tissues didn't really form. It depends on where that error occurred. That's where you know the defect. Okay, and so it can vary. It could be either membranous, muscular, trabecular, or apical defect. So let's take a look at that. So for membranous defect, that's located in the upper portion, more near the great arteries. Okay, so you'll see the membranous, like where the LVOT starts. And then the muscular defect is where the thicker portion, okay? Now there's two types. You can have an inlet and the outlet muscular one. So the inlet is near the AV valves. The outlet would be more near the outflows. Okay, it's just in its name. And then trabecular is that thinner portion located in the central portion of the septum, followed by the apical defect will be located near the apex of the heart. Okay. And the shunting that occurs is bidirectional, so be from right to left because of the circulation there of the cardiac cycle in the fetus. And so you would notice blood flowing in your different cardiac cycles from red to blue across that septum. Okay. All right. So here is an ultrasound view. Now, depending on the location of where the septal defect is, it all varies with the orientation of your probe or your plane of the heart. And so for your muscular defects, they're best evaluated in the four-chamber view. Yeah. I would say more like the apical, and then you turn maybe towards that transverse view, but they're most evaluated at the four-chamber view. Your membranous one is best evaluated at the LVOT view, which you can see here, and the short axis view. Okay, you'll also be able to see the membranous. See here, you can recognize in yellow. Now the inflow of VSDs are best evaluated in the short axis level of the aorta and the pulmonary. Okay, see here, you got the inflow inlet, and then we have outflow, which is best evaluated in the short axis view. You see aorta and pulmonary. Okay. Now, when you encounter a VSD, how do you measure the defect? First, before you even try to say, okay, a VSD is present, you do want to prove it in two views. I usually prove you see it in the apical because that usually is that standard, if especially if the baby's in that good position. We prefer to get a nice, good apical, uh, four-chamber view, but sometimes it's subcostal, it could be basal, but you want to prove this VSD in two different planes, okay? Once you prove, okay, it is there, then you measure. Okay, you want to place the calipers on inner edge of that septal defect on each side, measure straight across that septum. Okay, now I've seen where some tend to measure during with the color. They prefer for you to do without the color on, because it could overestimate that septal defect size. And so you want to just turn your color off when you're measuring. Okay, measure at the maximal diameter as well. Now, the color Doppler is what's going to help to confirm and really let the doctor know that yes, there is a VSD. See, here's the shunting of the blood moving across the septum, and so that's usually what I use the color flow to show that, not to measure the actual defect. Okay. Now, why you may heard why are perimembranous VSDs the most common in peds? You hear the most common VSD present or seen is the perimembranous. And so, but you want to think like, but in prenatally it's muscular, but then once baby born, it's perimembranous. Why does that occur? And it's only part of the process of the healing process. Now we know about the embryology development process and how that septum takes on a complex development phase, but it's in the healing process where we don't see the muscular or tend not to see the muscular unless they're large. But the little ones we don't tend to see postnatally. And that's basically what happens afterwards. There, it's a thicker tissue, and so after a while, the muscle grows and the defects will frequently close spontaneously with the muscular VSDs. And so that's why it's not as common once baby's born, because by then, typically those smaller ones, they close before, birth. Now, as for the paramembranous, because of its location and where it is, it's located with a thin fibrous tissue, no surrounding muscle to, heal over that defect. And that's why these defects often persist after birth. Okay. And so that's why in the peds department, typically they're noticing or they're seeing more of the paramembranous VSDs because it's persistent. It didn't close or it didn't properly close like it should. Okay, that's the reason why in that particular case. Now, I do want to point out with VSD, what happened in this era, the dying of those cells and those tissues and so forth, excessive amount is what caused that VSD to occur. Now, what if there's too much of that tissue? Okay, so if there's an excessive amount of that tissue, then this will lead to Epstein anomaly. Okay, so this excess tissue causes the displacement of that tricuspid valve, which we know it to be up in the apex region. And so let's look at Epstein. Okay, so Epstein anomaly typically occurs about 20,000 live births. What happens here? You see the displacement of the tricuspid valve. Okay, so normally or naturally, it should have a slight displacement from the mitral valve, somewhere in this region. But instead, with Epstein, notice is more near here. If you're not really aware, you may think, is that the moderator band? Because typically the moderator band is up in that right ventricle, but no, you clearly see that that is the tricuspid valve, but it's highly up into the apex. Okay, so that caused this large right atrium, which we see here, and a very small right ventricle. So you imagine once we add color, how this will appear. Let's take a look. We see this massive amount of atrium. See here, so that's what causes. It's going to cause severe tricuspid regurgitation, which may eventually lead to hydrops, as well as arrhythmias is associated because we know a SA node, a AV node is housed where? Is housed in the right atrium. Okay,
No,
and so we will know that if there is an issue in this right atrium, it may cause arrhythmia in that case because
no,
there's a disruption. Okay. All right. So here we can take a look
we
at
can
those
look.
tricuspid valve leaflets. Notice here with that right atrium,
Oh,
you see the
no,
enlargement there. You can see that tricuspid valve,
I'm
and you can still see right ventricle and the
Yes,
the moderator
let's
band.
see that. You don't.
Oh, oh, please mute yourself, please, Kathy. I think. Thank you. Okay, let me go back. Okay, and then let's see here. Okay, and then follow. You can see the foramen. Okay, so let's take a look. Once we apply the color flow, showing the color in the power Doppler, notice here. So it created this turbulence of flow and regurgent jet, and those peak velocities reached about 270 centimeters. So that's pretty high. Okay, that blood flow. This is a common sign that you will see in the severe tricuspid regurgitation. Okay, this is a example of a Einstein in first trimester. Look at that. And so here you can see where we have that apical displacement, followed by a very large right atrium. Once we apply the color Doppler, you see the demonstration of that blood flow. And we see that it's at, normally we don't use the spectral Doppler, but in this case, just to kind of prove what's happening with this heart, we apply the spectral Doppler and see that this blood flow levels are very high at about 120 in this case. Okay. All right. Now I wanted to compare normal to Einstein. Okay. So you see a normal case. We have left ventricle, left atrium, right atrium. Here's the right ventricle. Okay. Notice, okay, we have the mitral valve. Here's tricuspid. Notice it's a slight, like, insert higher, and then moderator band. But in the case with the Einstein, notice here with the left ventricle, and then we're way higher up. And so we see the tricuspid valve is it's very highly displaced there. And then here you can see the discrepancy. Notice normally your right ventricle, left ventricle, similar in sizes. Same with right atrium, left atrium, similar in sizes. But you can really see the discrepancy in sizes in the case of Einstein. All right. And that actually was it for part one. I don't know if everyone heard about my new book that just came out actually what 2 weeks ago. It's Yes, it says pass your boards review, but this book is so helpful in those cases where in your clinical setting you run across double outlet, right? Let's be honest, it's hard to remember all the different types. I feel like just about every congenital heart defect has maybe four types of its own. And so this book is just like a quick, nice review of everything. It can fit in your scrub pocket. I carry it around with me right in my scrub pocket. It's amazing just for your clinical setting, and then also for the pass your boards. If you're thinking about taking the RDCS board, it will be a nice review, pictures and so forth. So if you're interested, there is a QR code there to check it out and order. I ship everywhere. Right now, I have one being shipped to Italy, where we go everywhere. And so there is no boundary to where we can't go to get the book to you. And then also, if those who aren't a part of the international study group, join us. We right now it's good with three of us, but I feel like there's so much to learn from one another, and so it's the investment is really small, and it's a you can cancel whenever, but it's just we come together, we have these classes, courses, whatever, and we just break down things, and monthly we just meet once a month and just talk out hard. Right now we're going into hard things, but I really want to branch out into other specialties such as vascular and abdomen and so forth. But right now, the focus is on congenital heart um, topics and so forth. But we're going to be branching out to other specialties here soon. Okay. Now, one thing that I am doing differently, thanks to one of my members, uh, and it made sense to offer some type of certificate. Okay. And so if you complete 3 months participation, we now will give certificates to you. And it doesn't just stop there. I thought of this last night. And so there's different tiers that you will get recognized as for your participation. And so we have the 3 months certificate of participation. Then at 6 months, there's this advanced recognition of participation. You get this digital badge. And then by 12 months, you'll be known as a distinguished member at that case. And then by then you'll have a free access afterwards, where you can just join in anytime and catch up on some topics or so forth by the 12-month status. So if you're interested, you can also see this link to join in on the www.ultraprocert.com website. Okay. And that is it. Now, I am going to go over to the chat to see if there's questions, or you can, if you didn't get to type your question, you can talk it out with me. But let's go to the chat. Let's see here. Oh, no questions? Do we have questions from anyone? No questions. We're good. Okay. I do want to mention those that's going into our crash course. Crash course is starting on Wednesday, August 19th. And so I'm excited. Those are getting ready to do their board exam coming up in the next like 2 months. And so we're doing a crash course for 4 weeks. We're meeting every Wednesday at 6:30 p.m. and that's Eastern Standard Time. But I'm excited to what's to come with this group. I'm shocked there's not one question. Not one question. I do want to mention, guys, and I put it in the chat. If you want access to this recording as well as the slides, please email me. And I did list that in the chat. So that's UltraProCert llc@gmail.com. Okay, please email me. As for the members, of course, I always send a copy of the recording, as well as the slides. And then one thing I am doing differently, I'm going to attach a review of the notes in PDF. And so you'll have that in a PDF format of everything that we discussed today. Okay. Um, but it looks like we don't have questions. Okay. And always, I'm always around. If you think of questions after the fact, a lot of you all, I believe, follow me on LinkedIn. Please just message me or message me at UltraProCert llc@gmail.com. I am really excited about part two. Part two will be next Saturday, same time. The reason why two sessions are in this particular month is because I missed the session in July. It was just, I had my daughter's birthday and graduations. It was just so much happening in that month. And so that's why there are two sessions for this particular month. But normally it's just the one session. Okay. But next week we'll talk about the part two into the embryology era and things that could occur. Okay. Um, as for now, I see there are still no questions, but like I said, you can email me. Okay. I do have this recording, so I'm going to end the recording for now, and I will see you guys around. I look forward to seeing you around. Okay. Have a good day. And I will talk to you.
Ya, ya kan ada?
Yeah, you had a,
Ada?
oh, did you have a
Ada?
question? Oh, well, oh, okay. All right. So I will see everyone hopefully next week. Until then, have a great week, guys, and a good weekend. Take care.